Welcome to episode 13 of the Pro PA podcast. I'm your host, Prof G, and today we're continuing our pneumonia series, moving on to viral pneumonia. We'll cover an overview of viral pneumonia, its clinical presentation, and the most common pathogens by setting, including influenza, RSV, and COVID-19. Stick around for some clinical pearls and vignette-style questions to test your knowledge. Let's dive in. So first off, what is the Kinderpatho? What is viral pneumonia? Viral pneumonia is a lower respiratory tract infection caused by a virus, and this leads to inflammation in the lung parenchyma, which is the lung tissue, the alveolar area. Unlike bacterial pneumonia, viral pneumonia often causes interstitial involvement, affecting the tissues around the alveoli instead of filling them with pus or exudate, as in bacterial pneumonia. The viruses responsible disrupt the mucociliary defenses and allow secondary bacterial infections in some cases. So, who gets viral pneumonia? Well, really, all of us can get viral pneumonia. However, children are more commonly affected by viral cases. And the most common causes we see are things like RSV and influenza. Adults and elderly patients are also at increased risk for viral pneumonia caused by influenza and COVID-19. Immunocompromised patients are vulnerable to severe disease from viruses like CMV or cytomegalovirus. There are also other types of viruses that can affect immunocompromised patients more so than the average patient. So, what are the common viral pathogens by age and setting? Let's first look at community-acquired viral pneumonia. So, influenza virus is going to be the most common cause of viral pneumonia in adults. So, we'll see this peak in the winter months, and it can lead to secondary bacterial infections like Staph aureus. RSV, or respiratory syncytial virus, is most common in infants and young children under 2 years of age. We also tend to see it in elderly patients and those with chronic lung disease. Now, COVID-19 was a global pandemic and it affected all ages, but most severe, it was affecting the older adults and patients with comorbidities, associated with a spectrum of disease from mild pneumonia to severe ARDS. If you haven't already checked out my other podcasts, I have done one on influenza, RSV, and COVID-19 independently, so be sure to check those out. Now let's talk about some of the hospitalized or immunocompromised patients. So there are other viruses that affect these that we mentioned earlier. The cytomegalovirus or CMV is common in transplant recipients or patients with advanced HIV, and it is commonly associated with symptoms like fever, fatigue, and pancytopenia. Another virus that we see in this population is varicella zoster virus or VZV. This is a very rare cause, but it can cause viral pneumonia. It usually happens in immunosuppressed individuals or adults with primary varicella infection like chickenpox. Remember, they used to have these little chickenpox parties when kiddos were little. They would get one kid would get sick with chickenpox, and then they would get all the little kiddos together to get chickenpox as a young kid because it is known and has been known that adults that get varicella or chickenpox tend to have a much worse case. Now we have vaccines for that, so this is kind of old school mentality. Adenovirus is another one. It can cause severe pneumonia in patients like military recruits and immunocompromised patients in the close quarters. So, how do patients with viral pneumonia present clinically? Well, we often see them presenting with very nonspecific symptoms. So, fever, chills, myalgias, fatigue, sometimes a dry cough that can become productive over time. We also see in more severe cases some shortness of breath, wheezing, and pleuritic chest pain in more severe cases. So, physical exam findings, we might hear a few crackles, maybe some wheezing, diminished breath sounds. A lot of times we don't see too much on physical exam other than what you can kind of see with your eyes: a stuffy nose, watery eyes, patients look sick. But in more severe cases, we might actually see here signs of respiratory distress like tachypnea and accessory muscle use. So, how do we work up patients with viral pneumonia? Well, we're going to do some diagnostic testing. We have the rapid testing and PCRs for influenza, COVID 19, and RSV. Now, RSV we usually reserve for the pediatric patients, but in the other two, influenza and COVID, we can do rapid antigens or PCRs to help us work them up and come up with a diagnosis. We can also do some imaging, which we probably should if patients are presenting with pneumonia like symptoms, even in viral pneumonia, because we want to look and rule out bacterial pneumonia if we're going to make the diagnosis of viral pneumonia. We would typically see, if we had a viral pneumonia, a diffuse bilateral interstitial infiltrate. So kind of patchiness on both sides and not consolidated, not lobar. Okay. However, sometimes in like severe flu influenza, where we have a secondary bacterial infection, we might see some patchy or lobar consolidations in some cases. You might want to consider some additional tests, especially if your diagnosis is not clear, like sputum blood cultures, if you're thinking maybe a secondary bacterial infection, and even later on, for those immunocompromised patients, you might consider bronchoscopy. So, how do we manage these patients? Well, I think we best break it down between outpatient and hospitalized patients. So, the mild to moderate disease in outpatient setting, we're going to do mainly supportive care. So, hydration, antipyretics like acetaminophen, and rest. There are some adjunct antiviral therapies we can give based on the type of viral pneumonia that we have. For instance, influenza, again, we're going to start oseltamivir or Tamiflu within 48 hours of symptom onset. For COVID 19, if we have a patient that's more high risk, we can consider Paxlovid or remdesivir. For RSV, we're going to do mainly supportive care. However, in more severe cases, the ribavirin can be used. For severe disease, those that are hospitalized, we're going to definitely maintain their ABCs. We're going to give them oxygen therapy to maintain their SpO2 above 94%. For influenza, we can again continue the oseltamivir. We can add broad spectrum antibiotics if we're worried about secondary bacterial infection. For COVID 19, we can initiate some dexamethasone oxygen therapy to try to prevent patients from becoming worse, especially when they're hypoxic. And for the other immunocompromised type patients, for CMV, we're going to treat with ganciclovir and valganciclovir, or for varicella zoster, we can give IV acyclovir. All right, book med versus street med. So the book med is going to say treat influenza with antivirals within 48 hours, manage RSV with supportive care, etc. We've kind of seen those. The street med is going to tell us that many viral pneumonias are underdiagnosed. So we're going to think they have just a plain old upper respiratory infection with a cough. And so you'll definitely want to figure out these atypical presentations in adults and always think about the flu, viral pneumonia, especially during flu season or during the winter months. So clinical pearls. If you see bilateral interstitial infiltrates, especially in a young kiddo, think RSV. In an adult, you might want to think influenza. For abrupt onset high fever myalgias, definitely influenza. And COVID 19, again, can present from anything from completely asymptomatic all the way up through hypoxia, mild respiratory distress, and through ARDS. You definitely want to monitor the oxygen saturation closely. All right, now let's go through some buzzwords for viral pneumonia. So, influenza, we're thinking sudden onset, high fever, myalgias, secondary bacterial infections like Staph aureus. RSV, infants, wheezing, winter months, apnea, bronchiolitis like presentation. COVID 19, loss of taste and smell, bilateral ground glass opacities, and leads up to ARDS in some patients. CMV, we're thinking transplant patients, pancytopenia, immunocompromised. Okay, VZV, varicella, adults, primary varicella, and diffuse vesicular rash. All right, now that we've gone through that, let's get through some quick review questions to test our knowledge. So, first off, we have a 6-month-old infant presenting with rhinorrhea, wheezing, and a cough for the past 3 days. The rapid RSV testing is positive. What is the most appropriate management? Is it A, ribavirin, B, supportive care only, C, oseltamivir, or D, dexamethasone? I'll give you a few seconds. If you said B, supportive care only, you are correct. RSV is managed mainly with supportive care, including hydration, suctioning, and oxygen if needed. Ribavirin is rarely used. Question number 2. We have a 72-year-old woman who presents with abrupt onset of fever, cough, myalgias during the winter months. Rapid influenza testing is positive and symptoms started about 36 hours ago. What is the next best step? Should we A, start with supportive care only, B, start oseltamivir, C, prescribe doxycycline, or D, order a chest x-ray? What are your thoughts? Well, if you said B, start oseltamivir or Tamiflu, you are correct. Tamiflu is effective for influenza when started within the first 48 hours of symptom onset. In the vignette, look for signs and symptoms of pneumonia, including sounds on auscultation or rapid deterioration, change in vital signs. In a stable patient, healthy patient with signs or symptoms of influenza, we can do conservative management starting the oseltamivir. We don't have to get a chest x-ray on every single patient. All right, so to wrap things up, I want to thank you again for joining me on today's clinical medicine brief on viral pneumonia. We covered everything from common pathogens to their presentations, diagnostic tools, and evidence-based management. Remember, early identification and supportive care are critical, and antivirals can reduce disease severity in certain cases. Don't forget to check out the next episode in this pneumonia series. Next up is going to be fungal pneumonia, which you definitely don't want to miss. And then after that, we're going to be doing one on HIV-related pneumonia. And if you found this episode helpful, go ahead and hit follow, turn on your notifications so you never miss a new episode. And as always, this is the Pro PA podcast, where future pros in medicine are made. I'll catch you in the next episode.